Welcome everyone to our AIHI Webinar series. My name is Chrissy Clay and I coordinate these webinars for the Australian Institute of Health Innovation at Macquarie University. So our webinar today is on long COVID, utilising near real-time electronic general practice data to establish effective care and best practice policy. Our speakers are Professor Andrew Georgiou from the Australian Institute of Health Innovation and Associate Professor Christopher Pearce, the Research Director at Aurora Primary Care Research Institute. This project is a collaboration between us here at Macquarie University with the Digital Health Cooperative Research Centre, Outcome Health and 4 primary health networks in Victoria and New South Wales. Firstly, I'd like to acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumattagal people of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We acknowledge the traditional custodians of the various lands on which you all join today and the Aboriginal and Torres Strait Islander people participating in this webinar. We pay our respects to elders past, present and emerging. Now, the Australian Institute of Health Innovation is one of the largest research centres of its kind in the world and the largest in Australia. We're a research-intensive centre, creating evidence to inform system improvement. We have 4 university research centres and 3 National Health and Medical Research Centre funded centres. We collaborate extensively across our own centres and with system and research partners in Australia and around the world to deliver the research evidence like you'll hear today in our presentation. Now, you might have thought about doing a Masters of Research or a PhD. If you see something interesting today, or perhaps have a look at our website and you'd like to chat further, we're always on the lookout for high calibre candidates, so please contact us and we can further that discussion. So for today's presentation, I'm going to hand over to Professor Andrew Georgiou to start, but if you have questions along the way, please put them in the chat in the Q&A section and we'll get to as many as we can at the end. So I'm going to now hand over to Professor Georgiou to start our presentation.
Okay, presentation.
That's
okay.
It.
Can you hear me, Chrissy?
Yes, we can hear you in the presentations showing.
Okay, thanks very much and welcome everybody. So as Chrissy mentioned, my name is Andrew Georgiou. I am part of the Centre for Health Systems and Safety Research, part of the Australian Institute of Health Innovation. I'm going to share this presentation with Chris Pearce. I'll kind of introduce you a little bit to how the project started, the precursor to this long COVID project, some of the work we did leading up to what the long COVID work we're going to do, and also a few of the examples of the sort of work we did. Start my video. Okay, thanks, Chrissy, for reminding me. So first off, I'd like to acknowledge the team, the diagnostic informatics team, whose work I'm going to be presenting today. And I'll start off by this point. So general practices played a critical role in response to COVID-19. It wasn't just because they were often the place where people first made contact. They're also suppliers of information to the community. So they were suppliers of information in terms of the healthcare provided, the advice given, and how to mitigate the disease and protect the health of the community. General practice activity was also very important to identifying and monitoring the health of the community. It provided early warning systems of the spread of the pandemic and also using general practice as a means of identifying areas where healthcare was needed, had been delayed, or there'd been some misdiagnosis. So initially that was the sort of work that we did. So what we did, the project involved using the polar data from Outcome Health. It also involved 3 Victorian primary health networks. At that time, it was Gippsland, Eastern Melbourne and Southeastern Melbourne. That involved over 450 general practices. We also had access to New South Wales data from the Central and Eastern Sydney PHN and Southwestern Sydney, which had another 300 general practices. So we actually covered major areas of metropolitan Sydney and Melbourne, and also a big portion of the Australian population, about 30%. Moreover, it happened to be the areas where COVID was happening, particularly in Sydney. So Outcome Health is data custodian. It uses its population level analysis and reporting extraction tool to gather de-identified, secured electronic patient data generated from various clinical systems. The ethics approval came from the Royal Australian College of General Practitioners and also from Macquarie University. The value and the advantages of the electronic health data was, I can summarize in this way. It was longitudinal, so we had data over time. We were able to sort of see patterns, understand what was going on. It was comprehensive, so we were able to make comparisons by gender, by geography, by socioeconomic status. It was obviously a very powerful sample size, which allowed us to make some very meaningful analyses. It was also dynamic, timely and meaningful. So particularly in the early COVID days, we needed information and were able to provide it, as fast as we could produce it. We could also be outcome focused, and it was also used for quality monitoring. So what we did was that we got together. It was a collaboration. Digital Health Cooperative Research Centre funded the project. It involved us at the Australian Institute of Health Innovation, Outcome Health, Gippsland, Eastern Melbourne, Southeastern Melbourne, also the Royal College of Pathologists of Australasia, quality assurance programs were also involved. And we regularly put out these, we called them general practice snapshots. So we identified particular areas and were able then to sort of distribute them as far as we could. We distributed them nationally, but mostly I think the value was that it was used by the PHNs to inform their general practices, to inform sorts of work that they wanted to do, the areas to target. So that became, for the first 2 years of COVID-19, that was pretty much where our work was focused. And I'll just give you a few examples of what happened. So during the first wave, very early on, we noticed there was a major decrease in pathology testing. So in these graphs, you can see comparisons of Victoria and New South Wales. The bars in the background give you the number of cases back in the days when we actually measured COVID-19 cases. And then you can sort of see the pathology testing and see how they dipped dramatically in that first wave. In both Victoria and New South Wales. In Victoria, it was a 33% drop. In New South Wales, a 29% drop. Now, obviously, when you're not doing pathology testing, you're starting to worry about, well, what's this doing for the health of the population? Where are the deficits? Where are the gaps? What do we need to pick up on? Here's another example. HbA1c, the self-monitoring of blood glucose. People with type 2 diabetes are recommended to receive regular monitoring care using HbA1c as an indicator of their glycemic control. In Australia and overseas, the HbA1c monitoring is recommended at least every 6 months for well-controlled diabetes, and more often 3 months, say, for people who are out of control, whose results are not in the recommended range. So what we noticed early on was the number of HbA1c tests dropped by nearly 26% in Victoria and 19% in New South Wales. And the effect that had was that the percentage of patients who have fallen outside that controlled HbA1c level fell. So there was more people outside of the target control area. So it went from 31% in Victoria in 2019 up to 34%, 29% in 2019 in New South Wales to just over 32% in New South. Then in between 13th and the 30th of March, the Australian Government Department of Health released a list of temporary Medicare benefits scheme telehealth services and released some item numbers to cover for general practice payments for out-of-hospital patients. And this changed the landscape, and in a way, it changed the landscape related to telehealth, probably forever. So this is what happened. This is a comparison again between Victoria and New South Wales. Again, in the background, you can see the number of cases. So you see the early wave in March, April 2020, which was mirrored in New South Wales, and then Victoria got its second wave. And when you compare the face-to-face, which is the blue line, with the telehealth, which includes video and phone, you see how suddenly there's a dramatic rise. And in Victoria, for that second wave, it was telehealth, phone and video, which was carrying, the consultations that were being undertaken pretty much. It actually exceeded face-to-face for that period during the second wave. What we found was telehealth demographics. Females had a high proportion of their overall consultations via telehealth than males. The lowest utility of telehealth was for the youngest age groups. There were potential factors which might related to the lower uptake of telehealth, especially video in patients with low socioeconomic status. There were issues about employment and home environment. There were language barriers. There was issues about actual access to technology. So they're some of the things that we did in that early project. And so it was really pleasing to know that when we started to get a lot of concern about long COVID, we were able to go into a phase 2 of the project. So from 2022 to the end of this year, we've been working with pretty much the same partners: Outcome Health, Eastern Melbourne, Southeastern Melbourne, Central Eastern Sydney and Southwestern Sydney, and a DHCRC funded project around looking at deepening our understanding to better support frontline GPs and improve patient care. And that's starting to lead me into what Chris is going to be talk about. So I'll just give you a little bit of an overview. So around a quarter of the people who've had COVID-19 experience symptoms that continue for at least a month, and of those, 1 in 10 is still unwell after 12 weeks. Long COVID is associated with a range of overlapping symptoms. It could include chest and muscle pain, fatigue, shortness of breath, cognitive dysfunction, a wide range of mental health problems. There's not yet a standardized collective diagnosis for a wide range of post-COVID-19 symptoms. And so clearly general practice, which, as I said earlier, is really the primary contact for people facing long COVID. This is where we're going to see it first up. So having data about that is really important. It's really critical. It'll now allow us to identify and map some of the healthcare needs. It'll allow us to sort of inform the guidelines, the pathways, and maybe even predict some of the healthcare utilisation. So look, that's all I'm going to say. I'm going to hand over to Chris. As mentioned, if you have any queries, questions, put them in the chat box and we'll get to them at the end. So whilst I just swap over and bring Chris's presentation on, which should be there. Hand over to Chris.
Yep.
That's all working well.
That's all working well, and I'm now in front of the screen. Good.
You are.
Thanks very much, Andrew, for the background and the introduction, and thank you to the Macquarie team for inviting me here to talk. Look, I had to think about what I was going to title this talk. I started with, when data meets the clinical. Then I went through the dark arts of clinical practice, and then I landed on doing the impossible, understanding long COVID in primary care. Now, the reason why I've titled it that will become evident as I go through this talk. I wish to talk about how clinicians conceptualise their diagnoses and particularly how GPs work, because what we see a lot is researchers coming to research activities in general practice, and if they haven't got a clinical background, they often make some fundamental mistakes. I'm not talking about Andrew, of course, but it's something that we see a lot in the work that we do. So long COVID. Now, long COVID is obviously clearly topical. We're just coming to the tail end of one of the most significant public health events of our lifetime. And we are trying to understand what the aftermath of that is. Now, the first thing is there's a lot of talk about long COVID. And as Andrew has mentioned, you know, no one can actually define what that is. This is the WHO definition. And I'll read out the definition because it says, it is defined as the continuation or development of new symptoms 3 months after the initial infection. Now, you know, that's as broad as you can possibly imagine. So if you got shoulder pain, new symptoms, so shoulder pain 3 weeks after a COVID infection, we could call that long COVID, even though it's probably for the fact that you were doing rock climbing at the weekend. The next section, symptoms, is similarly as vague. There are, you know, some obvious high-level ones, but there are up to 200 different symptoms. But the key about it is the numbers affected, and you know, studies around the world are going to 10 to 20% of people infected are having symptoms that persist in some way, shape, or form, which means that we're going to see a very long tail of COVID-related impacts into the future. And that's not taking into account the fact that although we've sort of switched off all of the public health measures that we had in the past, there are still COVID bubbling through the community. You know, there was 30 deaths in Victoria last week attributable to COVID. And you will all, I'm sure, know people who are still getting COVID. And what we also know is that people who get symptoms persistently aren't necessarily those who are hospitalised or even very sick. So it's all quite a bit distressing at this point in time. So we need to understand a bit more what's going on. Now, just to emphasise the point I made before, you know, there's a lot. This is a study from Nature Science Reports that's outlined 50 long-term effects of COVID-19. And again, if you look down the bottom, you can see that the 5 most common symptoms are fatigue, headache, attention disorder, hair loss, etc. But that's taking a very high level, sort of big population approach. Because one of the things we do note, if we go down a step and look at specific areas, there are a number of even more troubling effects that we're noticing. So this is just focusing on neurological effects. And we can see that there was an increased incidence of things like stroke, cognition, dementia, migraine, and a raft of other things that are actually things that can have significant impact on a patient's life. Now, we can do that for neurologic, we can do that for cardiac, and you'll have heard things about myocarditis and inflammation of the heart, and we can do it for respiratory, all the way down the track. So we're dealt with a large number of potential problems that can go into the long COVID bucket. Now, just thought it'd be worthwhile taking a bit of time to think about how unique this sort of thing is. And the answer is, of course, it's not necessarily unique. When we look at, this is an article that took a look at the history of problems post-infections. And it looked at but basically I was looking for the impact of the Spanish flu epidemic. And interestingly enough, after that, there was an increased incidence of problems such as fatigue, headaches, Those of you who've read the book Awakenings or seen the movie will know this thing called encephalitis lethargica, where people basically froze for 15 years until the coming of dopamine. And that was thought to be a specific dramatic effect of influenza infection at the time. So it is actually something that we know that viral infections in general can cause. There's another study that I read that just looked at the impact of long-term symptoms after viral illnesses and compared them to COVID. You will have heard of a viral infection called glandular fever. Now, even in my time, glandular fever was called the 6-month tiredness bug because that was a virus that's known to doing that. We also have long believed that the Epstein-Barr virus, which is the cause of glandular fever, is one of the factors in multiple sclerosis. So it's not unusual for viral illnesses to have long-term effects. And I apologise for those of you who will be afraid to go outside after I've given this talk. So what we're trying to do with this at this very early stage is try and understand what long COVID is and what it isn't. And what the team here did, the first thing they did was they took all of the diagnoses that GPs are recorded in the software of the practices which Outcome Health extracts. And this is where we start to have a look at the complexity of it. So you can see here what GPs are actually writing, and a lot of this, part of what we had to do was try and work out how we would code this. And to understand the complexity of what we're doing, so you can see there up the top, there's a diagnosis called post-COVID, and we actually have no idea what the GP meant by that. Long COVID-19, clearly long COVID is a thing. Post-COVID syndrome, yes, that's fine. Cough post-COVID, well, is that something that's just been there for a week afterwards, or has it been there for a month? And it's a lot of sort of complexity to deal with. And it continues. Here we've got another batch, and you can see again up the top, there's actually infection spelt incorrectly, something we have to deal with all the time. And in amongst things that we're more likely to understand, like post-COVID infection lethargy, something that's well described. We have post-COVID swaying. Again, I'm not quite sure what that means. And we have serious conditions like post-COVID pericarditis, which is an inflammation of the heart. Then we have another, and you'll see here, we're down to like 1,999 diagnoses, and we haven't finished yet. Post-COVID bacterial, post-COVID infection. We have a series of inflammatory conditions down there, urticaria and asthma post-COVID infection. A bit further up the top, we have undertreated asthma post-COVID. So is that their asthma was worsened by COVID or some other reason? What we've done in the first instance, therefore, is just try and group these into something that's a bit more meaningful at a higher level. So we have multi-system causes, multi-system effects, respiratory effects. Now, to be clear, this is not the number of patients who have a multi-system problem. This is the number of diagnoses in that list that we have mapped to multi-system problems. So multiple systems, respiratory and cardiac and skin, respiratory, fatigue, cardiac problems, and so on and so forth. And there's about another 30 or 40 beyond that. So that's what we're dealing with. At this point, it seems to me that it's all looking very, very hard. So where I want to go now is to talk a little bit about how we need to understand how GPs work and translate it into an actual researchable outcome. So it's this translation process. Firstly, a few words about why general practice. Well, you know, the short answer is that 80% of the population see their GP at least once a year. And especially for conditions like this, general practice is the first port of call, and general practice is going to be where most of the care occurs. It's one of those classic power imbalance things where hospitals are large institutions with large budgets and good infrastructure. So they get the majority of funding in general and funding for research in this context. Yet it is general practice where the burden of disease falls. And if you want to make an impact on the health of the population of Australia, it is general practice with which you must work. But this is always a problem because especially if you're a non-clinical researcher, you tend to think that the disease, it's all about the disease and it's all about, you know, the treatment. If you have diabetes, we'll give you a drug or injection and you'll get fine. In reality, in general practice is nothing to do with disease. Well, that's not true. Disease is not nearly as important as what you might think. When I was teaching registrars in training for being GPs, I used to say you can always tell a good GP because they will go through a session, you know, a morning or an afternoon, and never make a diagnosis and never use a stethoscope. GPs are about managing people. So when we start to see patients with a condition like this, it is vague, it has no diagnostic test, and therefore our focus switches to what are the problems the patient is experiencing them and how can we manage it. But at the end of the consultation, there's a little box that says, you know, what's the reason for visit and what's the diagnosis? So we put something in. And the dilemma that we as researchers are going to deal with this is that because of that biomedical model, we are often as GPs forced to make choices. And the choices in this are, whilst if I see someone with fatigue or tiredness, you know, I will call that long COVID. But if I see someone who has developed atrial fibrillation, an irregularity of the heart, because of their COVID, I am more likely to give that a named diagnosis of atrial fibrillation and not necessarily note it as COVID, post-COVID. And if you go back to that original definition, you know, like it is long COVID, but it also isn't. There's quite a significant historical precedent for this sort of stuff. You will probably have heard of a thing called chronic fatigue syndrome. It was once called myalgic encephalomyelitis. And it shares a lot of features of long COVID or a number of post-viral syndromes, in that it has a constellation of symptoms. It may be tiredness, it may be headaches, it may be pain, it may be any number of things. The interesting thing about that, and the reason why I think long COVID is going to be a very interesting thing to research, is we have evolved in the last 30 years from a biomedical what's the diagnosis to a more holistic understanding of these sort of conditions. So literally in the 80s and early 90s, if you had myalgic encephalomyelitis, many clinicians thought that this was a non-diagnosis. didn't actually exist. These people were just making it up, or all had psychiatric conditions, and were very dismissive. We've now matured from that post, and we now understand a lot more about chronic fatigue syndrome than we did. And a lot of those learnings are going to translate into a lot of the long COVID stuff. But how we're going to do that it is going to be complex because of the number of factors that we have to deal with. But it's also because of the very, very complex ways we're going to have to manage this. Because again, there is no diagnostic test, so it's going to be a label that is applied. And applying labels to people can in itself be very difficult. There was a condition called repetitive strain injury, which was basically an overuse syndrome. It just went berserk in Australia, and it was almost unique to Australia in the early 80s. It had a very high incidence. And although it was a medical diagnosis, we understood that there was a lot of cultural, social, legal, because a lot of the repetitive strain injury things were workers' compensation. And literally it peaked and just then faded in the late 80s to a low level, and we basically never see it anymore. These are the same things that are going to happen with long COVID. We're going to see a lot of social and cultural issues into play in the diagnostic context. And that's another reason why general practice data is very good in dealing with this, because we have a lot of that social and cultural stuff embedded in our systems and recorded in our systems, because it is the bread and butter in which we work. I can see two patients with the same diagnosis and treat them completely differently because their social and cultural contexts are completely different. So when we've done a lot of this work, why us and what are we going to do with it? And this is the forward-looking thing. So Andrew's already mentioned who we are and what we are. As you said, we've got a number of PHNs, 4 in Victoria and 2 in Sydney. So I've already said why general practice. The next thing is why PHNs. Well, PHNs are an organisation that started about 30 years ago as things called divisions of general practice. And it was literally a thing about general practice is a lot of isolated practices. They're all small businesses. And the name division was because the model was, well, in a hospital, you have a division of medicine, a division of surgery, which has a role in both supporting the individual clinicians, but also trying to generate a common path for physicians. So they would say, we will treat this problem this way, and try and even out a lot of the individuality of individual clinicians. They've gone through several iterations. They're currently now PHNs, which have a slightly broader outlook, taking in the broader primary care centre, which is completely appropriate. But nevertheless, it is PHNs who understand the activities of general practice and the potential of general practice in their area. And what we're trying to do, what we're trying to do is use the data to change how general practice works. And you can't really do that without using your PHNs. So, and we're doing that by obviously unlocking the power of data. So what we do at Outcome, we have a number of data tools. Now, this is a sort of thing where we generated, those of you may remember, there was all of these phases for vaccine rollout. So we had, for practices, they could see who of their patient load was in the 1A, 1B, 2A, 2B phases. So they could actually both target patients and do some planning. The same deal when we came to COVID vaccines, we could look at the number of vaccines, looked at demand. So we were using the data at a population level to help PHNs and to help practices try and plan their workload. The other thing we can do is that we have an actual point of care tool, an in-consultation tool, if you like, that can give individual clinicians, GPs, I use this all the time, a view of their own data for that patient. And this is both, this one here is a mapping of the blood pressure over time. The next one is actually building in some risk tools. So we have the ability here to take the data. We need to apply our smarts to it. And then we need to feed it back both to the PHNs and to the practices. This started again 15 years ago, and I was working then with what was the general practice networks, and we did a project to do practice nurses. And we looked at how practice nurses were being used in practices. But the telling thing for me was, because we involved the Australian General Practice Network and not just the academics, we took the research findings and we were able to plunge them straight back into practice. This is the same thing here. As soon as we get the information, it's not going to be something that's going to take 2 years to filter through. We'll be able to do it, within months. So, and that's because changing practice across, 20,000 GPs across the country is going to be hard. And we need to do it a variety of ways. And it's not a one size fits all, which is why, again, the dealing with the practices and dealing with the PHNs who know the individual practices is the way to go. There's a number of sort of complex things are going to happen in the next few years. As I said, culture change. We're already seeing that, as I've described, with the myalgic encephalomyelitis is all in the patient's head, and I'm not going to do anything about this. They can all go away. To actually now a team-based arrangement, so you get the physios involved, all that sort of stuff. The more we use these tools and the more the artificial intelligence stuff gets applied, and we've got some experience with that now, it's actually going to change the clinical method, because there's going to be a lot more of the clinical software is going to not just provide information to the GP, but is going to provide resolution. So it's going to say, for this patient at this time, this is the best optimal outcome. And that's going to be new for most clinicians. There's a whole lot of stuff about regulation and ethics that's going to come into this that I won't go into now. But one of the important things is that data quality. So it's just to fold back to where I started with this, because one of the principles that we use is that if the end users, so if the GPs and the practice nurses get the benefit of the data that they generate, then they will be their own data quality custodians. So this is not, and in the end of this is not going to be about, we'll take your data and we will do some research on it. This is about telling them that you have your data. The better you make your data, the better the tools are that will be able to help you into the future. And that's a general principle that we can apply to everything. Thank you very much.
I'd like to share this, stop share. And
we have 2 questions.
Yeah. So I've got a question. Chris, you stated that general practice is where most of the care occurs, but I wonder how much detection and management of long COVID-19 is being affected by recent changes to bulk billing.
Right, Hills Women is hi, Farah. Look, the short answer is we don't know yet, because the changes haven't come through, in any way to make a significant impact. It will make a difference, because certainly, as you well know, many practices, including my own, have reduced the amount of bulk billing that they do over the last 6 to 12 months. And at the moment, if you're a full fee paying patient at my practice, the bulk billing rate doesn't cover half of the full fee. So clearly this has been mine is a practice that would bulk bill at the drop of a hat, but it just can't, and I don't know how anyone can bulk bill. The good news is that the recent changes is going to encourage more bulk billing, so that will be good. I think the complexity is going to be that a lot of this, we're already seeing a lot of this sort of long COVID stuff isn't in the pensioners and the healthcare card holders. It'll strike the young fit people who don't qualify for a lot of those bulk billing incentives.
See if there's any other questions there. No, I might just ask a question whilst we're waiting. So there was an inquiry recently, a parliamentary inquiry, which was good because it at least focused some attention on the issue. One of the things they did actually mention data, and they did mention artificial intelligence. Is that the sort of thing that you think we need to sort of go? Is how you making sort of developing tools that might help decision making or care management?
Look, I don't think we'll be able to do this without the application of some artificial intelligence. I think the complexity of the data is too great. And I think and also not just the diagnostic stuff, but bringing in the other stuff that I mentioned, the socio-demographic data and so forth. And I say this because a lot of the stuff that we've seen that have dealt with this in the past, they have taken a long time because they've taken the traditional, hierarchical regression approach. So you've got to get the data, it's got to wait for, a couple of years, et cetera, et cetera. And I think the AI tools are the only way that we're going to be able to process data fast enough and also be responsive. One of the, problems we have is that as each wave of COVID comes through, its effects are slightly different. And remember in the beginning, the first couple of waves, it was all about you couldn't smell, and the smell would take months and months. Well, we're not seeing so much of that lack of smell popping up in the current waves.
Continuing on, so how in the early days there was a lot of emphasis on setting up clinics, long COVID clinics, and doing registries, but I've heard less about that recently, and there was some issues about funding and everything. What's happening? I mean, Victoria, New South Wales, obviously different. But in Victoria, are those long COVID clinics still operating? Would you send someone to a long COVID clinic? Is that what's going on?
So I was tempted to say a long COVID clinic in a public hospital is a waste of time. I probably have to be a bit more measured than that. So there are certainly some long COVID clinics, certainly in Victoria. I don't know in New South Wales. I suspect there are. And they tend to be multidisciplinary in their focus. There are a couple of issues with them. One is actually correct, the funding. If you have an orthopedic outpatients clinic for doing all of the knees, what's the funding for a long COVID clinic, which is probably going to be more expensive because of the nature of it. And the other thing, of course, is the burden of disease, as I said, is going to fall on general practice. If 10% of people with COVID are going to have long-term symptoms, then either you're going to open a long COVID clinic that's going to work for 3 hours a day every day, or you're going to have to work with GPs, and I think that's a no-brainer, that one.
There's a question that's appeared there from an anonymous attendee. Can you comment about the representatives of the practices participating in the outcome health data collection?
Yep, absolutely. It is representative. We've got 2 rural PHNs in Victoria, and we've got sort of the others are all urban, and they go from inner city, central eastern Sydney covers inner city, as does southeast Melbourne in Victoria, right out through the suburbs. We are not good for remote, obviously. But like it's, I don't know, it's 26% of the Australian population. It's good. If you want to target a specific subgroup, that we need to deal with that. But otherwise, no, it's completely representative. The next question from Abish is, how are GPs dealing with long COVID in the present day? And we are feeling our way, is the short answer. We are feeling our way. We have well-established sort of previous pathways to do things. So we have now well-developed programs to have multidisciplinary care teams. We work with physios, we work with dietitians, et cetera, et cetera. So we have those things in place. We have the most powerful thing often, which is the relationship with the patient. So we have to understand, the first thing you said is, how is it actually affecting you, rather than focusing on the symptoms. Where we're struggling is when and how to apply a label. And there are a couple of conditions, postural orthostatic tachycardia syndrome, which basically when you stand up, your heart races and you feel very dizzy. In fact, a lot of the cardiac problems and some of the dyspneas, we're not quite sure what the optimal management of those is yet, and how much, and this is the important thing, is how much we need to investigate things. Because the short answer is, for things like myalgia and encephalomyelitis, no investigation ever made a bit of difference. Okay, so we've got a question. Can outcome health data used to drive decision support in real time? Yes, it can, and it actually does already. Not in this case, but we have things in that tool, which is called Walrus, that drives decision support. My practice, which obviously I'm a bit of a Walrus user for obvious reasons, but before I bring the patient in, I open up Walrus and I flick through all of those screens that you saw, and I get a feel for what's going on and what's needed and what we might need to do before the patient walks in and tells me the problem. Because you need to use the opportunities you have to drive change with patients, not just necessarily deal with the problem they've got.
Chris, what about policy and making changes? Obviously, there's interest in it from government, but they work very slowly. But obviously, the whole concept of data has to be sort of done now. It's not like something. Is there a likelihood that there might be some support in this area, or there might be some thinking going along that might change some things?
Well, I would hope so. Again, if I look back at that practice nurse thing that I spoke about, which not only was about practices, but it also changed policy at the federal level. One of the things the government was doing at the time was creating item numbers for nurse to do things. But one of the things that our research demonstrated was nurses were doing a lot more than just what an item number described. So the research was in part responsible for what was then just a practice nurse subsidy, where practices were given X amount of dollars to subsidise a practice nurse. Why was that the case? Well, again, because we were dealing with what was then the Australian General Practice Network that was plugged into the policy of the federal government, and we were doing presentations and talking to policymakers all the time. And I think that's the challenge for us with this, is to make sure that we're engaging with the policymakers who we know are struggling with what to do with this, this long COVID stuff right now, and try and make sure that any decisions they make are at least influenced by the data, rather than by however governments tend to make decisions sometimes, which seems to be a dark art.
So, anonymous attendee again, what are your thoughts, Chris, about generative AI, e.g. ChatGPT, and its potential uses in Australian general practice?
I have colleagues who are using ChatGPT right now, but for formulaic stuff. So write a letter to the local council to support the application for subsidised housing, stuff like that, and it's really good for that. I wonder about its use. I wonder about what its applications use are going to be in general practice. I don't think it's going to be as widely used as what people might think. And I get back to this thing where general practice is about people and about relationships. So I've never been worried about computers affecting my work, because when you're in pain or you're worried, you're going to want to talk to a human, and ChatGPT isn't going to cut it. I think there's some roles in some various things such as triage, or a few other bits and pieces, but it may affect other aspects of the profession. Certainly, I think not ChatGPT, but other sort of the visual recognition things. If I was a radiologist, I'd be a bit worried, but not general practice. We have survived the coming of antibiotics, the specializations that thought they could cure everything by, with a magic drug or a procedure, and we'll be there long after lots of specialties have bit the dust. Is the RICGP looking at guidelines for the safe use of ChatGPT? They are, but they're a long way from having any constructive view of the moment. And one of the problems about this, of course, is that ChatGPT that you see now could likely not be the ChatGPT or any other variation that you'll see in 6 months' time.
Okay.
Could I just jump in with a question, Chris?
Okay.
It's Chrissy here. I was interested to see at the start of your presentation, you showed us all the different ways that a GP could enter their diagnosis at the end of a consultation. And then you also mentioned that when you can show, as with the work that you were doing with Outcome Health and with Andrew and so forth, when we can demonstrate benefits to the user, such as nurses and doctors, GP practices, then that leads to an increase in the data quality. So sort of one works with the other. But I was just wondering if you had some other ideas, particularly for our researchers in the audience, about how to generate that improvement in data quality and also that engagement in these sorts of projects from our GP users, nurses, PHNs.
Yeah, look, yes, I do. Okay, so well, the first one I've already mentioned, which is, the providers, the data need to see benefit, so they'll be their own data quality officer. I think, the other one is you need to understand the social and cultural context of which, when you're doing research in this space, you need to look at that. you need to get as close to the data as you can. So the process that we're doing, where we're looking at all of that stuff post-COVID, is good. You need to, if you're doing clinical data, you need to somewhere have clinicians in your system, and I'm not talking about in your steering group or anything like that. You need to have clinicians in your system to understand both what you're seeing, but also in talking about what the implications are. One of the things that we do in outcome in our work is, and again, not with Andrew because they're good, but we get lots of researchers who write a paper with a conclusion, and we look at the conclusion and go, that conclusion is absolutely not feasible in clinical practice. You do not understand how GPs work. And I'm just trying to think of another one. There was another one. No, that's it. That'll do.
Good tips, thank you. And I'm sure Andrew's team's all over it.
So I think we're getting close to the end. Unless a question pops up soon, which I don't see, what I might do is, on behalf of Chris and myself, thank you, Chrissy, for organising this. It's been great to get an opportunity to talk about the work, particularly together. Got Chris across over to Sydney, and which has been a plus. We can spend the time now talking about lots of things. It's great that we've been able a chance to do the AIHI seminar. I think they're a great opportunity for everybody. So keep up the good work, Chrissy. Thank you all for whoever all those people out there are. Thanks for turning up, and I think it's available on tape, on video, if through the link.
Yes, everyone who's registered today will receive a link to this recording when it goes up on our YouTube channel, and on our YouTube channel are all the webinars that we've had over the last couple of years as well, so there's plenty to catch up on. So
Chrissy, is there anything else that I've neglected to do other than thank Chris and yourself?
No, we're all good, I think.
Okay.
Thank you, everyone.
Thanks very much.
Thanks.
Bye.